common complications that we see are vertebral compression fractures and fractures of the wrist and hip. Does anybody have questions about osteoporosis? Okay, I'm going to move on to osteomalacia. The book doesn't get into a lot of detail on osteomalacia, but I want you to know a little bit about it. The main thing to me is that you know the difference between it and osteoporosis. These bones are softened rather than decreased in density, and I forgot to turn my lecture structure on, but I'm turning it on right now, so we haven't missed much there. Soft bones rather than decreased in density like you see with osteoporosis. Caused by lack of vitamin D, and that keeps calcium and phosphorus from depositing properly in the bone. I think the best way to think about it is if you think about a branch that's kind of green and you can bend it, but it doesn't really break fully. So that's more like what these people are going to get. Osteoporosis is more like that kind of dead brittle branch where it pops open completely. These people more bend and break a little, but not fully completely. Primary causes are from lack of sunshine or lack of dietary vitamin D. It can also have secondary causes like medical conditions and medications. Risk factors are pretty much what would make sense looking at causes. Things like poverty and homelessness, poor nutritional intake, drug and alcohol abuse, strict vegan diet, all those are going to interfere with people's vitamin D intake. Any disorder that would decrease our absorption of vitamin D is also going to be a problem. And also living in some sort of environment where maybe we don't get enough sunlight to develop vitamin D. Also being an older adult for a lot of the reasons that we've covered before. What do we see in these people? We see muscle weakness in the shoulders and the pelvis, and a waddling, unsteady gait. They may have bone pain. That typically occurs between the joints, not actually within the joints. But clients may also get hip pain that decreases their mobility. We see bone tenderness on palpation. Our long bones may bow, kind of like we talked about with the branch. They may get spinal deformities from that softening. And you don't have to memorize this, but you can also see something called, for my test, you may need it for other things, but loser's lines or milkman lines are the kind of pseudo fractures. So on an x-ray, they're kind of just a line, not really a full break. But those areas are weakened and susceptible to further injury. I think I'm going to skip. Yeah, we're skipping that one too. And just a reminder, if I tell you in class that we're skipping it completely, it is not stuff you need to know for the test. So just mark through it, and I'm not going to ask you questions about it. So pharmacology, what do these people need? They need vitamin D. So that's what we're going to give them. We're going to give them a supplement to increase intestinal absorption of calcium and phosphorus and promote their bone calcification. It's a PO form. It can cause hypercalcemia, mental and physical retardation in children, and they can also, if they get too much, calcify their soft tissues, also some GI symptoms there. So what are we going to do? We're going to monitor electrolytes, kidney function, and red blood cells. We also want them to avoid magnesium-containing antacids and laxatives, because those can increase the risk of them getting toxic levels of vitamin D. This particular medication, this is not on your slide, has to be kept tightly covered and protected from light so that it doesn't break down.
What medication? Vitamin D.
Protected from light.
Oh.
Okay, that's all we're going to do on that one. Enid, is your student mic on, maybe?
Is the student mic open?
It's open.
Yeah,
She wants to gossip.
Thank you. We were getting some extra noises here. The next one is Paget's disease, also called osteitis deformans. Basically what happens in this is the bone is breaking down and reforming so quickly that it's not doing it well. So it's structurally disorganized and doesn't necessarily form even in the right shapes. So they're getting deformities and getting fractures from it. I pulled a little bit, I don't even think this disorder is in your textbook, but it's in the slides, so I want to know a little bit about it. Bones end up weak and malformed. Oops, I skipped something here. Let's see what I skipped. It's more common in males. seldom found in anyone younger than 40, but occasionally, and then it increases rapidly after the age of 50. You do not need to memorize these risk factors. Signs and symptoms. You also do not have to memorize this whole list. I'm trying to pare it down for you guys a little bit because there's a lot of stuff in this lecture. But you do need to know that pathological fractures of the poorly constructed bones are often the first sign that we see of this. I have to flip the next one on because it'll say that. On the next slide it says that I just had flipped over. So most clients are asymptomatic and pathological fractures are usually the first sign that you're going to see. It's also important that skull deformities are particularly problematic because those deformities can start to compress brain tissue, resulting in impaired brain function. And people, you may notice warmth over the areas that are affected, which makes sense because there's just so much activity going on there, but those areas may also just feel warm. Once again, you don't have to memorize all of that, you just kind of need to know those things we talked about there. We're skipping the diagnostics on this one, so cross that one out. Pharmacology. Most of the people with Paget's will not need treatment as it's typically localized and causes no symptoms. So most people won't need to be treated. If they are actively symptomatic, treatment is going to involve pain relief with aspirin or NSAIDs, bisphosphonates to help regulate remodeling, and calcium and vitamin supplementation to provide the nutrients they need to build healthy bone as it remodels too quickly to try to improve the health of that bone. The next slide talks about another treatment, bone metabolism regulator. I don't know that you need to know a ton about this. When I first started nursing, people used a lot of calcitonin and lots of patients were taking it. It's kind of not as favorable these days. We don't see a ton of people taking it anymore. It's important to know that allergic reactions are common though, which is maybe one of the reasons we reduce use. So the clients have to be tested intradermally for hypersensitivity before it's given. It also has some cancers have been associated with it, which may be another reason that use has declined. But it's just kind of important you guys know what that medicine is if you see it on something else. They can take it nasally or sub-Q/IM. And as you see, one of the major side effects is anaphylaxis, so that's why we're going to check them first before we get to them. If they do take it, they need to rotate nares. So one nostril daily and rotate. Daughters are going to rotate injection sites if they're taking it one of those routes. And that's it for that one. On to osteomyelitis. This one we actually do see a lot of, at least in Ponca. The floor world has a lot of orthopedic surgeries. We see a lot of osteomyelitis. Do you guys see a lot of that in Stillwater? You do? Okay. Yeah, I was gonna say, this is one we see, I feel like, a lot. Osteomyelitis, basically it's a bone infection. Most commonly it's caused by bacteria. Staph is a common cause, but it can also be a parasite, a fungus, a virus. It can be kind of anything that gets in there and grows. I don't think we're gonna worry about, you don't have to, I mean, basically an exogenous is one that comes out from outside the body, so the infection comes from outside. Endogenous means the infection is gonna come from inside the body, so that kind of all makes sense. And contiguous means that it comes from an area right around it, so basically it got infected from something that's on their skin and moved over. So those are the three directions they can get it. It can be acute or chronic. People with skin, sinus, ear, and dental infections are all common sources. Urinary respiratory can be common. You don't have to memorize all those things. People with total joint replacements are particularly susceptible to this, so that is kind of important. That's something to watch for in any of our joint replacements. And then also arm and hand bones are common infection sites in clients who abuse illegal substances because of the unsanitary conditions and frequent venipunctures. And I know we did have a client that basically fit that exact profile that was in the hospital for like 6 weeks last year, not this year, but basically they kept her there to do her long-term antibiotics there because these people take a long time with lots of times multiple antibiotics. So what are the risk factors for this? A penetrating trauma, that makes sense, that would get your infectious agent deep down. An open fracture is going to be a risk factor, so that's going to open up your bone to outside pathogens. Like we talked about, any infection elsewhere in their body is a risk factor. Diabetes is a risk factor for lots of things, but they don't have good circulation, they can't fight infection well, so common, especially in this group. If they're immunocompromised, obviously, that's gonna increase their chances. And also, like we talked about alcohol or drug abuse, and that must not be on your original slide. I tried to write things in orange that were not on your original slide, so if it's in orange, you probably bad. What do they look like? The pain that they have is generally localized, feels constant, and then pulsates with increases in movement. Fever is generally 101 or more, but may not be true in older adults, remember, because their immune system doesn't react as well, so sometimes they don't look like you would expect them to look. They generally are going to have things like warmth, redness, and swelling at the site of the infection or the wound. And we talked about the fact that it can be acute or chronic. The chronic ones will actually not necessarily have those inflammation systems, but sometimes will form more of a tract of drainage inside, and then eventually that drainage will escape. So like get a sinus tract that's kind of drainage. And I'm not going to out any particular Tonkawa students, but we actually were talking about some bone injuries the other day, and there was someone there who had had a chronic version of it from like an elbow surgery when she was in high school that eventually started to drain fluid, and that's how they figured it out. Diagnostics for this one. White blood cell count is going to increase, obviously, maybe as much as double. Their ESR rate may be elevated for as much as 3 months. So like you can see, it's going to take them a really long time to get rid of this inflammation. What does ESR stand for? You guys that are here, because that's easy. Oh, sedimentation rate, what's the first word? Erythrocyte. What does it mean to us? What does it tell us? Right, but why is it important to us, I guess? Like we know we look at white blood cell counts because why? Because they show us infection, right? What does ESR show us? Inflammation, yeah. So ESR is a good measure of inflammation. We talked about a lot when we talked about some of the arthritis stuff too. These people are gonna need blood cultures from 2 different locations. And then a bone scanner and MRI can detect the changes in blood flow. In your book, on the top of page 1559, it gives you a good graphic of kind of how that process works, how that inflammation gets sequestered, and how that affects the bone, just kind of if you want to look at the progression of it. What do we do with these people? They're difficult to treat. They require extensive long-term therapy. We use contact precautions to try to keep this from spreading. What do we use for contact precautions to learn? What does that look like? What? Close counts. They need long-term IV access. Typically this is a PIC or some other central line. And I have a note here that I don't care what word you put the blank on your slide as long as you have down that they need antibiotics in the central line. Is there a blank on your slide that's not filled out? Yeah, I don't know. Yeah. Either one of those will work. Those are the important things I want you to get out of it. And then you can also use hyperbaric oxygen therapy. For some people, surgical intervention is going to become necessary for these. If you look at that figure on the top of 1559, what a sequestrectomy would look like is going to become fairly clear. They're going to go in there and get that necrotic bone out of there so that the tissues around it can try to heal. Bone grafts, they're going to transfer some healthy bone in there to try to fill in that area and prevent necrosis to further areas. Bone grafts are only going to work if there's some healthy circulation to feed it, basically. You put that healthy bone in there, and if it can't get nutrients, it's just going to die like everything else around. Unfortunately, that last one is what we see a lot from these. So a lot of people end up with amputations in order to remove the dead infected bone and keep that infection from continuing to spread. So we would like to not end up at that 3rd place. So how do we treat it? Long-term IV therapy, they're going to need IV antibiotic therapy, 2 or more medications, generally for at least 30 months, which is a long time to be on those IV medications, and it's expensive to treat for that period of time. You may also use direct wound irrigation with the antibiotics. It can be extremely painful, so pain medication is a must for these clients. And sometimes, like with the I've had a Ponca. Yes.
It was done.
Say that again. Oh, 1559.
Our book doesn't go to 15:59.
Well, then I don't want to know that. Hold on. Well, it's not even close to that, ever.
Does it look right?
Oh, I did, but we don't have any.
I will, remind me, and I'll put it on Blackboard. How's that? I'll find it. So I don't have to do it while we're in here. Okay, so that's about it for osteomyelitis. We're really just going to treat it with a lot of antibiotics, try to keep it in and give them pain medicines. I guess that's what I started to say. Is it gets into a tricky place because alcohol and drug abusers have a tendency to get it. Then we get them in the hospital, and they're harder to control their pain because you have a certain tolerance built up, and sometimes nurses have certain biases to giving them too much pain medicine. So it's just once again, patient's pain is your patient's pain. So we don't want to leave people in pain and punish them for what we don't agree with in their lifestyle, right? So just a little, because it did come up sometimes with that person that we had in the hospital. Okay. Bone cancers and tumors. We're not going to talk about this a lot. Obviously, you can get tumors in bones, just like you can anywhere else. It's rare for it to be a primary bone cancer. It's more typical for it to start somewhere else and metastasize to the bone. Obviously, the weakening of the structure and additional pressure on the structure can lead to pathological fractures. And because bone is very vascular tissue, the cancer can continue to metastasize easily from that side. We're going to skip bone deformities because Mrs. Martinez already addressed contractures in her other lecture, which is part of this stuff, and then we're going to talk about spinal curvatures when we get into assessment. So you can pretty much, I think, skip that one. And then osteoarthritis is the next part, and again, that's something that Mrs. Martinez, your book deals with it more like in the immunity section, and so Mrs. Martinez went ahead and lectured over it there, so you guys have kind of already had that concept. So what we want to use our time for more in depth is sprains, strains, fractures, and how to care for those things today. So a sprain. The definition of a sprain is excessive stretching of a ligament. Typically it happens involved in a twisting motion from a fall or a sports activity. Results in localized pain and swelling and inflammation. How do we want to treat it? Our first treatment is rest, compression, and elevation, which we'll look at in more detail in one of the later slides too, but I think you guys are probably already familiar with kind of that mnemonic. We want to use NSAIDs to decrease the swelling, decrease the pain. We want to immobilize it, although typically there can be partial weight bearing, but the more we can keep people off of it, the better and faster it's going to heal. Some people need arthroscopic surgery to actually repair those. One of the points that makes in your book is in terms of emergency care, a sports injury should always be considered a fracture until it's proven to be something other than that. Next is a strain. Quick review of this content, because Mrs. Martinez talked a lot about these things too. This is excessive stretching of a muscle or a tendon, sometimes also called a pulled muscle. Often happens from a fall, from lifting a heavy object, or from exercise. It can range anywhere from being a mild inflammation to a severe pain and disability. Has swelling, bruising, tenderness, and sometimes an inability to use the muscle group. How do we treat it? We can alternate heat and cold on it. Once again, we're going to limit activities and exercise. Use NSAIDs and steroids to reduce swelling, treat pain. They may also need muscle relaxants. What do muscle relaxants do for us? And what does that prevent? Cramps. It helps to prevent the muscle cramps that can go along with these things. We'll talk about those more too. People with fractures get a lot of muscle cramps too. These also can require surgical repair. Next one is dislocation. This is where the ends of two or more bones are moved away from each other. If it's partial, it's called a subluxation instead of a dislocation. So basically what happens with these is a strong external force is applied to the joint and moves it past its normal range of motion and basically just kind of pops it out of there. These people have pain, decreased mobility because it's not where it goes, so it doesn't move properly. Altered contour, so like some visual deformity a lot of times in that joint. Sometimes there's a deviation between the length of the extremities then because one of them is not in the place where it's supposed to be. And it will have a rotation or an abnormal position. PCP can perform a closed reduction on these with some sedation because it's going to hurt, and then immobilize it while it heals back into place. They can sometimes need surgical repair too. Treatments are going to be very similar to what we looked at with strains, NSAIDs, pain meds, muscle relaxants to try to keep them comfortable while they heal. And on fractures. So quite a bit of time talking about fractures. A break or disruption in the continuity of a bone. It affects mobility and or sensation. Usually an excessive force is applied to the bone. Most commonly it's trauma-induced, typically from a fall or a motor vehicle accident, are what we see most commonly. Healing takes 4 to 6 weeks. How many of you guys have had a fracture in this room? So everybody's got like some experience to work off, or not everybody, but at least half of us have some experience to work off of here. So obviously healing is going to be influenced by the severity, which bone it was, how well it's managed, whether it gets infected, whether the person has good nutrition, and how the blood flow is. How do we classify these? So the first way we can classify them is by the extent of the break. A complete fracture is one that goes across the entire width of the bone and it's divided completely into 2 pieces. An incomplete fracture is going to go through only part of the bone. So the bone is still one piece, but it's not one whole piece anymore. A comminuted is a shattering of the bone into multiple fragments. So now we don't just have 2 pieces, we have lots of pieces. Which one of those would be hardest to heal? Yeah, that last one where we have lots of pieces that we're trying to get back in the right places. We can also classify them based on how much soft tissue is done, whether they're sticking out or they're not sticking out. So a closed fracture is a simple one. It does not extend through the skin. There's no visible wound on the outside of the person. An open fracture or compound fracture is one where the skin is disrupted and has an external wound from the break in the bone. There are pictures, we'll see if this page number's right. Pictures on 1032 of open and closed fractures. If anybody wants to look at those, you can know the fracture anywhere. Oh, where I was doing I'll have to work on that. If I was using a different version of the book. Cause of the fracture. So we can also classify by cause. A pathological fracture, these can also be spontaneous or fragility, results from minimal trauma to a bone weakened by disease. So basically, a pathological fracture is a fracture that happens when there really wasn't enough force to cause a fracture. So it kind of tells us that something else is going on, basically. And so we have to start looking for other causes. Fatigue or stress fractures result from excessive strain and stress on a bone. We see a lot of these in like the feet, like runners will get stress fractures just from overuse without any actual trauma. Compression fractures result from a loading force on the long axis of the bone. So we talked about primary cause is generally trauma, especially from MBAs and falls. Other risk factors include sports, rigorous exercise, malnutrition and bone diseases that weaken the bones, genetic factors that predispose us to weaker bones or diseases, and also immobility, because what happens when we're immobile, we kind of talked about with osteoporosis. What did we talk about? They need weight-bearing exercises, right? Because that helps them make that bone stronger. So people who are immobile are not weight-bearing, those bones are not being strengthened, so it makes them more likely to get fractures. What do they look like when they have a fracture? Moderate to severe pain is typically our most prominent symptom. You may also see bruising, limb deformities, alterations in alignment, unnatural rotation of the bone. They may have uneven lengths, so maybe a shortened extremity. They may have limited or absent range of motion. They may also guard or stabilize an injury because it hurts, so that may be what you notice, that they're holding it and they're not moving it in a normal manner, even if they're capable of it. Your only sign sometimes may be a change in neurovascular assessment away from the injury. So distal to the injury, you may see pain and a swelling and a change in the neurovascular status, and that may be the only thing that you really have to go on. There's a tiny bit about diagnostics. We're going to talk about these a little bit more later, but basically, X-rays help us diagnose, you guys know that. May take multiple views in order to compare things. A lot of times, anything like we're looking side to side sometimes too, like when we do our assessments, we're looking at both sides. So does this arm look different than that arm? Does this angle look different than that ankle? And that can give us a lot of information to compare the patient to themselves, basically. CTs are used to detect fractures in complex structures. And MRIs are more helpful to us when it's soft tissue damage, so damage in a joint or something like that. Like especially like knee injuries where you're tearing your meniscus and stuff like that, MRIs are more helpful to us. How do we treat them? The first step is reduction. Reduction basically means we want to realign the bone like we want it so that we can promote healing. Reduction is not always necessary, but it is the most common way that we treat simple closed fractures. They can do that in two ways. We can do closed reduction, which is basically the primary care provider pulls and external pressure after providing sedation to get things lined back up and then stabilizes it when they're aligned. Open reduction for more complex things means the surgeon has to go in and visualize the bone and reposition it and immobilize it, especially if there are fragments involved. And then they can use internal or external fixation to hold that in place while it heals. I think that's what our next slide we'll talk about here in a second. Is fixation. I really wish this page number was because I really want to go through this. Oh wait, that's the one I got right. Check that out. Okay, so fixation is the use of surgically placed hardware to maintain alignment of the bone fragments during the healing process. Internal fixation, I didn't take a slide, did I? Internal fixation involves pins, screws, plates, all that kind of stuff that you stick in there. Those things may or may not be removed surgically later. And then after we get all that put in place, we put a cast, a glue, or a splint on after the skin is closed to hold it all in place while it heals. External fixation involves pins and wires that are inserted through the skin into the bone. And then they're connected to an external frame. And the picture is on 1042. I did double check that one, and that one looks right. So. Obviously with that, you're going to need excellent skin care at the pin sites to keep those people from getting infected. And it seems kind of barbaric when you look at the picture because basically they've got pins sticking out and they've got kind of this frame that's holding it in place. But the truth is that actually external fixation has less blood loss than internal fixation, doing it that way. So there are some advantages. It also allows access to that area. So if it's an MVA, for instance, and they have lots of wounds and you need to do wound care in that area, the external fixation allows you to get to kind of all those areas to take care of them. Whereas if you have the cast or splint around it, you can get to those wounds, so it's going to increase your chance of infecting those areas. So even though it seems bad, there are some advantages to it. And then we have to immobilize. So once we have it fixed in the place we want it, we need to hold it there and give it a chance for the bone to regrow. So limited movement provides an opportunity for the fracture to heal. Sometimes we do this with a bandage or a splint, sometimes a cast, sometimes we even need tracture to immobilize things. So splints are on here first because that's kind of the most mild way we use of immobilizing things. They can be a rigid splint or it can be inflated with air. In splints, we can kind of adjust as the swelling is reduced or increased. So how many of you have had a fracture, but did they put a cast on it right away? No, they didn't. How long did they make you wait? 3 days, what'd you say? Until the swelling went down, right. That's why they want you to wait 3 days. Why is that? Right, because the cast would be too big if we put it on when you're fully swollen. The other thing is if we put it on, often when we first find the fracture, you're not done swelling yet either. So we stick that hard cast on you and then your body wants to keep swelling and we cause circulation problems below the injury. So that's the reason we wait to put the cast on because they are rigid basically. Splints allow us to kind of adjust for that swelling. So a splint you can have put on pretty much right away if you're only going to need a splint. But a cast itself usually has to wait a little longer for that. Cast is rigid, cast can be fiberglass or plaster. It's important to know the difference because the care is different between the two of those. Plaster can't get wet. You can't like grab it while it's drying because it's still soft. It takes a long time to dry. We'll talk about this a little more in detail. Having a cast can reduce pain because it's going to hold it very stable and can allow earlier ambulation. Depends on the cast. Not all casts are weight bearing, so you want to make sure that you kind of know what your client is getting and you educate them on what they can and cannot do. Because a lot of times they need a boot over that cast to walk on. They can't just, you don't want them to think that it's basically like putting on a shoe and now they can just do whatever they want, because it doesn't really work that way. And it can interfere with their healing and damage their cast. So be sure to check with your provider, find out what their activity rules are, and educate your clients. What's next? Then that brings us to traction. So, have you guys seen traction in your hospital rotations yet?
Yes.
Has anybody seen that in here? Okay, we had actually not probably all year last year, but just last week somebody came up from surgery with back traction. So it does happen occasionally. It's basically the application of a pulling force that helps reduce, align, and rest that muscle. So I think there's a picture of this in your book too. Let me see if I put it right. Yeah, 1041, there's kind of a little picture. That one is a skin traction, so basically it's kind of a boot that's applied to the area and then it's kind of pulled over the edge of the bed. So basically what that's going to do is pull it and it kind of helps with muscle spasms, but these people still get a lot of muscle spasms and they can't really move to kind of get a more comfortable position. So they're going to need a lot of medication to keep them comfortable. We'll talk a little more, but they also, because they can't move, you've got the immobility issues. So you can't turn them off and debrief them like you want to and reposition them every 2 hours and all that kind of stuff, because they pretty much have to lay in that one position in retraction. So as nurses, they're going to need a lot of care to keep them from getting complications and to keep the pain under control. Decreases muscle spasms, but like I said, they'll still get some. Prevents or corrects deformity and tissue damage. Two-pine skin, which is what you see in that picture there. Let's see, what do I want to talk about skin traction? Skin traction is usually shorter term, and you can only use lower weight. So if you think about that, when you put the boot on, there's only so much weight you can put on that boot before it's going to kind of pull it away from the area. Whereas if you do skeletal traction, which actually surgically screws into their bones, you can use more weight and you can use it for longer. So, I see your faces, though it sounds awful, doesn't it? But it's basically a system of pulleys that are going to hold weights kind of off the end of the bed. As the nurse, so the weight is a prescription, basically, how much weight is going to be on there, how long they're going to have it. So as a nurse, you just kind of want to be in the habit of looking at that every time you go in the room, because those things can get moved around. Your client can slide down the bed, and if their foot's like against the bottom of the bed, then that pulley isn't really pulling on their foot anymore because they're slid down the bottom of the bed. If the weight has pulled down on the floor, or somebody has loosened it, or it's being supported on something, then they're not getting the prescribed amount of weight. So it's kind of like when you walk in the room, you check the IV pump, you check the IV side every time you walk in there to make sure your fluid's running, it's running the right rate. Same thing with someone on traction. You just kind of visually, every time you go in the room, make sure it looks like that it's hanging. Basically, the weights need to be suspended freely, so they're hanging in here. Can be set up by PT or by the nurses themselves. I know when I was on the floor last week, the nurses kind of set it up and then they grabbed the PT guy really quick to make sure that they set it up properly, because it's hard, I mean, I think sometimes we're going to nursing school, we think we're going to get out of here and we're going to know everything, but the fact is the stuff you don't do, you don't remember all the time. So they had the PT guy, at least I know on our floor, PT is fabulous. Like they have one guy who really, really knows what he's doing, and so he came in and kind of got everything fixed up and made sure it was done right. But as nurses, you are responsible. It's the middle of the night, you may not have PT there, so you're the one who has to get it set up. Let's see, fracture treatments. So analgesics and narcotics for pain control. You want to give them a multivitamin with iron to promote bone growth. NSAIDs that are going to decrease pain and inflammation. They're going to need anticoagulants because they're not going to be able to move, remember, so we've got to decrease their chance of getting a DVT or a fat embolism or PE from that. They're also going to need skeletal muscle relaxants to decrease muscle spasms and pain. Why do they need the multivitamin with iron? How does that help? Everything else is pretty clear. Why do we want to have that? What does iron do for us? Right, helps our red blood cells. And so it's important for them to have good circulation and good oxygen carrying capacity to get nutrients to all that bone that we're trying to grow in there. So it improves their nutrition and improves their hemoglobin hematocrit. Decreases their chances of anemia. So then most of these meds we've already covered in some other area. The only one we really haven't talked about yet is skeletal muscle relaxants. Going to use these to decrease muscle spasms and pain. Typically a PO form is used. How many of you have taken a muscle relaxant? What does it do to you? Yeah, it kind of knocks you out, doesn't it? At least for me, that's what it does. I haven't done it very often, because it really like, so drowsiness, dizziness, those kinds of things. They may also have dry mouth. So you want to make sure that you're supervising if they're able to get up. So these are the people that aren't in traction, obviously the people in traction aren't getting up, but you may have other clients. Any kind of musculoskeletal injury can result in muscle spasms that you're going to have to medicate with this kind of medicine. And so supervising ambulation, making sure that they know not to drink or use other things that are going to depress their CNS while they're taking it. They need to drive or operate potentially hazardous material responsibly, pay attention to how they react when they do those things. As far as dry mouth, they can use hard candies to kind of get rid of those symptoms if they want to, and they need to learn to make slow position changes too because of the dizziness. So, same things that we talked about with the meds that have orthostatic hypotension. Questions so far? Are we doing okay everywhere? Tonko, I just want you to know you're like my big screen right now so I can see whether you're paying attention or not. Okay, nursing assessment. Subjective data. Because musculoskeletal issues are often related to traumatic injury, your first assessment on these clients is always going to be airway breathing. That means even if they're screaming and you can see their femur sticking out through their thigh, your first assessment is still airway breathing circulation, because you don't know that they don't have an internal injury that is more likely that they have both sticking out of their thigh right now. So always, 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 that's your first priority. You can also check for blood in their urine. That's one way of telling whether they've had some other kind of trauma. As far as assessing the fracture itself, you want to stabilize and elevate the area to reduce discomfort as much as possible. You're going to find out your usual pain things, pain level, what makes it worse, what makes it better. It's important to find out and some of this data here is kind of not just fracture related, but all of musculoskeletal assessment. So you want to find out their whole history of musculoskeletal injuries, not just their immediate stuff, because sometimes an old injury as you age can cause you more trouble. So sometimes some kinds of musculoskeletal issues may be due to an injury they had 25 years ago when they were playing football in high school. So it's important that you assess all of their history of injuries. When you can, you want to treat their pain first before you try to complete an assessment. Especially with rib fractures in particular, it's important that we treat that pain, because what are they going to do if it hurts to take a deep breath? Yeah, they're not going to breathe deep for us, and so they're just going to exacerbate their chances of getting pneumonia or other issues. So pain relief, especially with chest fractures, is important because that way they're moving, but it's really important with anybody with a fracture because you want them to be moving. So the better you relieve their pain, once their fracture is cast or stabilized and they can be up and moving, the better their pain relief is, the more they're going to move and the less problem you're going to have with immobility. So that's not just musculoskeletal, it's kind of everybody. The better you relieve their pain, the more they're going to move for you. It's going to decrease your other issues. As far as musculoskeletal assessment, you want to know if they can perform their ADLs by themselves, if they're using any assistive or adaptive devices. And you want to know about changes in mobility, and then I think I added function too to this, because musculoskeletal issues can especially interfere with their function. We want to know about pain, weakness, changes in range of motion. We want to know about risk factors. Do they have a family history of musculoskeletal disorders? Osteoporosis and gout specifically are often generational in nature. We want to know if they have chronic diseases like diabetes, immune diseases, GI diseases, cardiac diseases, endocrine diseases. Any of those things can decrease their nutritional absorption, give them poor wound healing, lessen their immune response, so those things are all important. We want to know about their lifestyle. Young men are at the greatest risk for musculoskeletal injury due to MVAs, while older adults are at most risk from falls and soft tissue injuries. We talked about that already. Obviously, occupation can obviously contribute to injury potential, anywhere from fractures from a really active, dangerous job, or maybe things like carpal tunnel from a desk type job. So that can go either way. We want to know if they partake in any weight-bearing activities, because that's going to make their bones healthier. We want to know about high-impact sports, obviously, and tobacco and alcohol use. Tobacco slows the healing of the bones. Alcohol use contributes to deficits, and then they also have poor nutrition on top of that. Also, I put on here, alcohol contributes to those like hold my beer kind of traumatic injuries, so it's particularly important to know about alcohol use. Drug use, you're also going to look at medication use. Some prescriptions can promote losses in bone density. What kind of over-the-counter meds are they using for pain relief? what kind of herbals? There are a lot of herbals, like if you look at the shelves in Walmart normally, there are lots of herbals, you know, that are gonna help with your arthritis or whatever. So it's important to assess these people for those, for what else they're using. And also if they're having any illicit or illegal drug use, because that's gonna affect their nutrition and their bone health as well. When we're looking at nutritional intake, most people don't get enough calcium no matter what, and when people are allergic to dairy or lactose, that sometimes goes up even more because they're not taking in even the things that we normally do take in that have calcium in them. So keep that in mind. Strict diets like vegan diets are going to sometimes be an issue. If they have recent weight gains or major losses, you want to know about that. Poor diet. Obesity is another one that's going to cause extra strain on those joints, especially knees. As you get older, people who are obese a lot of times will have trouble with their knees. And then also eating disorders can be an issue. And then also lists on here financial hardships, which will impact their nutrition as well. So, you know, we've talked about that before. Cheap foods are not always the healthiest foods. So sometimes the healthiest foods are the more expensive stuff. So it does make a difference in our nutrition. Objective data. So what are we looking for as nurses objectively? First of all, we're looking for posture. What is their build? How are they aligned? We watch them stand and walk. We want to look at the curve of their spine, and I might have changed that one a little bit too. So I'll try to ask everybody questions this time. What is lordosis? So Water, do you know what that is? What? I think I heard it. Sway back, right. Lordosis is sway back. Let me see, let me check I have a page number here. I'm not very confident about any of those. That one is page 1009 is your picture of these three things we're going to talk about right here. So yeah, lordosis is sway back, common in obesity. Tonkawa, what's scoliosis?
Curvature of the spine.
Which way? They're all curvatures.
Yes. Laterally.
Okay, yeah. So side to side curvature of the spine. So we see a lot of that more in kids is when it's typically diagnosed. And Enid, what is kyphosis?
Humpback.
Yeah, so that's the humpback, the dowager's hump that we kind of talked about in osteoporosis, where basically it's the opposite of lordosis. So the spine is, concave versus convex, which goes the other way. But there are some pictures in your book too that will help with those things. Okay, we're going to look at the length, shape, and symmetry of their extremities. We've kind of talked about why that's important already. We're going to look at gait. Most musculoskeletal injuries are going to affect gait either initially or eventually. So gait is, you want to see the stance before they move, how well they move when they do move, their balance, their steadiness, how easily they're able to keep a stride. We're going to look for limp or asymmetrical movement when we're looking at gait. So posture, gait, and then range of motion. Assessment of range of motion tells us about the injury and how it's interfering with their function. We want to do active range of motion first for joints, major joints or areas of concern. Then we can do passive if whatever's going on with them limits their motion through active range of motion. Observe for crepitus. So what's crepitus? Kind of like a crackling, yeah, that you hear the bones popping, cracking sound. And then also pain, tenderness, and swelling of their joints. If you need, once again, let me check this page number. On page 110, that one's right too. There's a little review of like different motions, like pronate, supinate, circumduction. If you're not remembering kind of what those motions mean, there's a little graphic there that'll show you what those mean. 1010, you're right. I'm pretty sure that's not what I said, but you're right. Okay, so then next, we're gonna look at neurovascular status, and I know you guys have already covered these very well with Mr. Baird. So these are the things we're gonna check. Distal to their injury. We'll talk later, one possible complication of these musculoskeletal injuries is acute compartment syndrome. And that can be one that can cause them to totally lose a limb if we don't catch it quickly. And so these are the things we're gonna look for. And in that in particular, pain is your single best indicator that they're having acute compartment syndrome. So if they have pain that is out of proportion to their injury or is suddenly increasing, even though their activity hasn't necessarily changed, then you're gonna really wanna do the rest of this assessment and figure out whether they're getting good circulation and signals below their injury. Did we get all those? Next, we're going to look at the wound itself. What type of wound is it? Is it a blow? Is it a fall? Is it a crush? Is it a penetrating? There's slightly different things we worry about with different injuries. A crush one, for instance, all that like massive damage at one time to the muscles can actually cause your client to get something called rhabdomyolysis, which we had a couple cases of that recently at the hospital in Hong Kong too. And it can cause them to have kidney failure basically because their kidneys cannot eliminate all that stuff so quickly, which isn't necessarily what you would think about with a musculoskeletal injury, but that one in particular, that can happen. And it also can cause some other issues like cardiac issues because it releases all the potassium out of those tissues really quickly and can drop their electrolytes and stuff. So that's important. Penetrating injuries, there may be foreign bodies that need to be removed, but as it says in the on your slide, you do not remove large foreign objects because they may be blocking the person from bleeding out on you. So if you pull that out before you're ready, it can cause them to suddenly have a lot of blood loss. So we leave those big things in place until we have providers there who are ready to deal with that. And that's what the tamponade word means basically. I can give you like a euphemism to help you remember that. It's basically the same, basically like a tampon for the wound. It'll help you remember it. It keeps it from bleeding out on you. Okay, this is a new slide, so take a picture if you want to take a picture. This kind of summarized musculoskeletal diagnostic testing instead of talking about it under every single place. So it's a very simplified list. I don't care about you necessarily knowing a lot of details about it for now, especially the lab stuff, but those are some of the indicators that may tell us something. We may see increases or changes in disorders of the bone and muscles. What you'll notice about those is a lot of those, though, are not specific to bone or muscle, so they can tell us we might have a bone or muscle problem. They can't tell us for sure that it's a bone or muscle problem. We're going to have to eliminate other things that might be affecting those things, too. People won't know for sure. Diagnostic x-rays, like we talked about, those are good for seeing bones. CTs are kind of an improvement over x-rays. They give us more structural views from multiple angles and kind of give us a better complex view of what's going on. MRIs are our best bet for examining tissues and soft tissues. For some tests, you're going to use contrast. What do we need to check for when we do contrast? Allergies, and what else? Yeah, so we need kidney function. We need to know what their allergies are. We need to know what their kidney function looks like before we give them a contrast. Ultrasounds, you guys kind of know about those. Biopsy involves taking a sample of either a muscle or a bone. EMG involves electrical impulses, basically. So when we look at an EMG, we're not necessarily looking at structural components, we're looking at how electric signals pass through that tissue, basically. What else? Arthroscopy is going to involve inserting a tube and allows internal visualization. We can use that diagnostically, and we can also use that for surgical repair, sometimes of musculoskeletal issues. It's more invasive, so it's going to involve more aftercare and frequent assessment of neurovascular status, infection protocol, post-procedure restrictions, if they get to that point. How do we care for fractures immediately? So what's our immediate care of a fracture? What's the first thing we're going to do? We're going to do ABCs. So ABCs and a quick head to toe. Next thing we're going to do is remove their clothing while wearing above or below the site. Then we're going to remove any jewelry. Tonkawa, why are we taking the jewelry off? Is that because we want to steal it? Tonkawa?
MRI or CT maybe?
That could be it, yeah. We might need to remove metal for those reasons. Why else do we want to take it off?
So it doesn't get stuck.
I think I've heard that. Say it louder. Swelling, yeah. We want to get that jewelry off while we can because it's going to cause further damage if it cuts off their circulation. So as they swell, it's going to get harder to get it off. And if we don't get it off and they swell around it, their circulation is going to be compromised. So that's why that's an early thing that we do. Then we're going to apply direct pressure for any bleeding. We're going to maintain warmth for our client and keep them supine. Enid, why do I want to keep them supine? What is supine?
Improve circulation.
Yeah, it's going to improve circulation to the things that are most important to me, basically. If I don't have enough blood volume, I want it in their head and in their vital organs. So I want to keep them flat. So we're going to check neurovascular status. We're going to compare things bilaterally whenever possible. That gives us a better idea of what our injury is and how severe it is, like we talked about. We're going to immobilize it, splint it, and recheck our neurovascular status. Stillwater, why am I rechecking my neurovascular status there? After I splint. Right, because I want to make sure I still have good circulation on the other side of my splint, that I haven't cut it off by restricting movement and stuff. And then the last thing we're going to do is cover open wounds with sterile dressing until they can be dealt with appropriately. We want to limit tissue injury and long-term disability. We want to promote bone healing. Common nursing problems that we might be planning for with musculoskeletal issues include pain, weakness, impairments in mobility. The injury itself may predispose them to further falls and injuries, so safety is kind of an issue after that too. And those are all kind of very physical issues, but they also cause a lot of psychosocial issues. So it may keep them from being able to work. It may change the way they function. They may have some issues with a change in their role, with not being able to do the things they would normally do for their family, or not being a provider, or not being able to take care of their kids the way they normally would. It may keep them from participating in like a favorite sport or a hobby or things like that. I mean, how many of you, so this came up in conversation with talking about students, injuries. How many of you had an injury in high school that interfered with like a sport that you were playing, where you missed something that was really important to you? So it wasn't just the injury itself, because that healed, but sometimes it's the psychosocial stuff that doesn't, get better as quickly. So it can also interfere with body image, especially if you're talking about something like the jets where you get deformities based on illness. Anxiety and depression are also common with chronic pain. So if those chronic disorders exist and they're not healing, then that pain can really contribute to further decline. So the point of this slide is to make sure you realize we're not just dealing with the physical stuff with these people, they also have a lot of psychosocial stuff that goes along with these kind of injuries. Keep watching, it's 1:30, let's take a break, how's that? So let's do 10 minutes, because we've gotten through really quite a bit.